What's a disc protrusion? I've heard herniation, bulge, protrusion. What's a protrusion?
Yeah, there are terms, and disc injury to me is good because it is accurate. That's what it is. Once we get down to terminology, it sort of depends who you're talking to, but essentially what they're referring to is the back of the normal disc annulus, which is the outer rim, is kind of in line with the back of the vertebral body that it connects to on either side. And when it sticks out, kind of like squeezing down on an Oreo cookie when the white stuff comes out, it sticks out beyond the margin of the cookie. Where it generally goes is backward, which is where the spinal cord is. So the larger the protrusion, the more it's pushing into space that wasn't designed to house that disc material.
What about this severe canal stenosis, 7.4 millimeters AP? What is that?
That is the loss of space or constriction immediately around the spinal cord. So there's a bony tunnel that's made up of a number of different structures that the spinal cord sits in and kind of passes through. And as people develop disc injury or arthritis or thickened ligament, there are a number of things that take up that space. And as that space is lost over time or related to an injury, it eventually gets down to a point where there's no more extra room for the spinal cord and the protecting fluid. And that's when we start using terms like moderately severe or severe. And that's usually a sign of something that is, especially in somebody so young, opening up the conversation of surgery to remove that narrowing, open up that space.
So that means that his spinal canal shrunk by 7.4 millimeters?
Yes, it means the tunnel for the spinal cord at that level is getting close to half its original size.
I was wondering because 7.4 millimeters, I'm not great at math, but isn't that like 1/100th of 7 meters? It doesn't seem like that much.
7.4 millimeters is very small. The spinal cord, there's differences, but it's usually somewhere around 6 millimeters. So when you get down to a millimeter, which is really, not very easy to see from a few feet away, that's all the extra space between the bony tunnel or the disc protrusion and the spinal cord, which is in the cervical spine, controlling most of our body.
And so a normal canal is what? How many millimeters?
Yeah, so everyone's different. We have people that are born with, by birth, they have smaller bony tunnels, and as we get older and the tunnel gets smaller, they tend to show up in offices like mine at a younger age, in their 40s or 50s versus 70s or 80s. So there's no measurements of what the normal canal size is, but we could make an estimate if we had images to look at. Regardless of what the normal size is, once you get down to a number that is very close to the spinal cord number, we get concerned about spinal cord injury, chronic compression, inability to have the cord or the nerves return to normal if it's not decompressed. So, his situation could have been that he was on the lower part of normal and maybe at a 12 millimeter canal. And so he's lost 5 out of those 12 millimeters, and he has maybe a millimeter or a millimeter and a half left before he starts directly strangling the spinal cord.
Did you look at the actual images?
I did. It's been a long time, but that was part of our protocol as we reviewed the images and the report while the patient was in the room.
I actually put together a little video of some of the images. I was hoping maybe you could walk us through.
Yeah, if I could stop you right there. So that's a really good picture. And that's a average to possibly larger than average normal sized tunnel. So I can't measure it because it's on a screen and it's magnified. So I don't know what my referencing ruler would be, but based on the surrounding structures, if we look at that little I'm not sure if you can point to the spinal cord. I think you probably know where it is.
There.
Exactly. So that kidney bean right there, if we assume that's 6 millimeters, his tunnel is probably about 13 millimeters, which is within the range of normal. So he's gotten close to losing half of that space. Do we need to hit play or do we go image by image?
Yeah, we can, but let me ask you. So what you're saying is we are seeing stenosis right here where I have the arrow.
Right there where you have that arrow is higher up in his neck, and that's perfectly normal.
Okay. Okay.
I guess I wasn't clear. I was using this level to give you an estimate of where Mr. Smith's normal tunnel size would be at the C5-6 level before disc injury.
All right, and it was the other levels that you talked about, C1, C2, C3, where there was no acute findings.
They're all normal. So we expect a normal size, his normal baseline tunnel size at those other levels.
Gotcha. An MRI, just if you can explain for us all, it takes pictures in different levels, or
so
what is?
We get so accustomed to looking at them, we think it's a picture, but it's really not. It's an image representation based on magnetic field and electrical pulses that create this we call picture. And so we take it of a certain body part, and it's done in different orientations to create these two-dimensional slices of a three-dimensional object that radiologists more so and us were accustomed to looking at. We can kind of scroll through the images and get an assessment in our minds of what the 3D picture looks like, what structures are where they need to be, what's normal, what's abnormal, how abnormal are they, and a big part of coming up with our diagnosis.
Okay. For the record, I'm going to introduce this, or attach it, I guess, to this deposition as Exhibit MR20. I'm going to hit play, doctor. Bear with me, it's slow. You tell me when to stop.
So this is just, I don't really use play, but you can keep on going. But this is going from kind of the base of the head down to the shoulders with individual cross-sectional cuts through the neck.
Okay.
If that makes sense.
What view are we looking at there?
That's called the axial view, which is the cross-section. It's kind of like cutting slicing through, like you would cut through a tree.
All right. What is this view?
This is a view from the front to the back that will not be helpful for what we're discussing.
What is this view?
That's a side view. So that's slicing from the left side or from the right side to the left side sequentially.
Why is this a good, helpful view?
It's a grainy image, but it shows you what we're discussing, and that is a large disc herniation at the C5-6 level.
Can you annotate on your screen? Do you know how to do that?
I don't. Can you?
Yeah, you should be able to hit annotate up there next to where it says like share screen.
Annotate. I have that. Are you seeing any of that?
Yeah, perfect. What is that arrow indicating?
So that's right at that disc bulge, that gray material that's pushing into the darker black trace.
So that's where we've got the shrinking of the spinal canal because of the bulge that's in that area.
So I moved the arrow. I'm not sure how much lag is in there, but the arrow is pointing to the backside of the disc bulge right at its contact with the spinal cord.
Okay. So that is that what's causing or was causing Mr. Smith's issues?
Absolutely.
That's what you worked on?
That's what I removed all that gray material that's pushing on the spinal cord.
In your opinion as to what caused that issue that you got purple arrow pointed at?
Yeah, like I said, there are a number of different factors, but when we see someone who has essentially a completely normal spine, no signs of degeneration, and a large disc bulge like this is generally a sign of a single specific acute traumatic injury, which in his situation is a big enough level of pathology that it would be very hard to be symptom-free with this pathology going through regular life. Meaning he would have very likely sought medical treatment when this occurred, or had some significant symptoms.
Will you define pathology for me more than anyone? I think I misuse it.
Just an abnormal structure. So essentially when a radiologist writes a report, anything that says anything other than normal is considered pathology.
Okay. I always thought it meant like trying to figure out what happened, what caused what.
No, it's just a statement of an abnormal function, abnormal anatomy, something broken, something displaced, just an abnormality.
All right. I'm going to stop sharing this. Now,
yes.
What are the findings and impressions in the 4/12/2012 CT?
Basically, it's normal. They just go through a list of things like there's no fracture, there's no alignment issue, no soft tissue abnormality, and no significant arthritis.
What, if any, bearing does that have on your opinion as to causation for Mr. Smith's injuries and pain?
So again, understanding that it's MRI to CT scan and 6 years have gone by, with all that in place, it's far more likely than not that his disc herniation at C5-6 occurred between whenever this CAT scan was done, which would be 4/12/12 and 11, whatever the first MRI was done, October of 18, the disc herniation happened in that time.
And the herniation that we're talking about, is it one that would develop chronically over time, or is it more one that would most likely be caused by an acute traumatic event?
Anything's possible, but 3 scenarios are that it just happened slowly over time, that it happened all at one time, or that there was a low-grade injury which was exacerbated. And by the look of the remainder of the neck, it appears to me most likely that it happened all at one time, or was a much more mild injury that got significantly worse all at one time.
Right.
Probably in the past, temporarily related to when that first MRI, October of 2018, was done.
I want to show you what I'm going to mark as exhibit MR16. It's the imaging of that 2012 CT. Can you see what I've got on the screen?
Yes.
What are we looking at here?
That's same view that we looked at in the MRI, a scan that's a cross-section scan. We're just starting really more in the mid part of the head versus the top of the neck.
All right. Can you tell me when to stop if you see anything significant, please?
Sure. It looks like this is going to play for 6 minutes.
I'm sorry, I can speed it up.
Now we're in the cervical spine, which is a pretty normal sized canal. Now we're down in the thoracic spine, also normal.
Okay.
Cervical spine again. There's really no evidence of any significant disc injury through there.
We see no
or significant degenerative change.
No stenosis.
Correct.
Right.
I made the comment before. I was just finishing the answer that I had before about the 3 options for the disc injury. The reason I said it's much more likely that it was an all at one time injury, or if an exacerbation, if he had a disc injury, say in 2013, after his initial CT scan of that size, it would be very likely we would see significant degenerative changes that would have occurred in that 5-year period, which we don't see on his October 2018 MRI. Once the disc is injured, the degenerative process speeds up quite a bit. So it looks like a fairly acute injury. Like I said before, fairly recent to the October and November 2018 MRIs.
How often do you have a patient who has a prior read with negative findings involved in a wreck and then they have a positive read?
Not often enough to make what I'm doing now easy. So it's rarely that big of a discrepancy that we have those images. It does happen, but generally in people that have more underlying problems, it's more of a subtle change.
Meaning this is more cut and dry?
To me, it is, yes.
Meeting.